Hi there. December 2017 saw the introduction of the renewed cervical screening program in Australia and the release of the associated updated cervical screening guidelines. This has presented some management challenge to clinicians as we all try to adjust to the updated guidelines and the change in management. What we're going to do today is aim to discuss some of the more commonly encountered clinical challenges to try and assist us in making sure that we're providing the right test at the right time to our patients with appropriate follow-up in place. All of the cases discussed today and the information are taken directly from the updated guidelines, which can be found at the website shown on the screen now. So case 4 today is looking at the scenario of a symptomatic woman. So a big change in the new guidelines is that there is a specific section of the guideline that deals with symptomatic women. And this is a very important step in assisting us to make sure that women presenting with symptoms are managed in an appropriate manner. So case 4 involves a 40-year-old woman who has presented to you with recurrent post-coital bleeding over the past 3 to 4 months. In this scenario, a co-test, so again our co-test is a liquid-based cytology plus HPV DNA, should be requested, and the history details relating to the nature of her abnormal bleeding and her symptoms should be clearly recorded on the request form. There's a lovely flowchart in the guidelines that you can see on the screen there now that do outline management of symptomatic women. So that's important to be following that and be familiar with that. Now, there has been a little bit of confusion come out of this management of symptomatic women. We have found that some laboratories regarding reporting of these results, even if the co-test is completely negative, some laboratories are recording this as a high risk result, which has resulted in some anxiety for both clinicians and women. What we need to keep in mind is that these are investigative tests rather than screening tests. So if a woman is presenting with abnormal symptoms of persisting post-coital bleeding, of unexplained intermenstrual bleeding, these women need to be thoroughly worked up and reviewed by a specialist gynecologist to get to the bottom of their symptoms. So really in these scenarios, the co-test is just forming part of the investigative workup on the way to referring these women for specialist review. Some of the confusion has come where quite commonly young women who are using hormonal contraceptives will commonly experience breakthrough bleeding. So we do need to consider rationalising when we may do the co-test. So for example, if a woman is in the first 3 months of a new contraceptive pill, or if she's in the first 3 months of an implant-on implant, where there may be a clear explanation for their bleeding, we may not rush in with that co-test. But it is about balancing having a low threshold for investigating women, appropriately investigating and referring women with clearly abnormal bleeding, and thinking about other causes. So thinking about STI screening and pelvic ultrasounds as part of the workup of these women.